squeaking, again, very well studied recently, but it is now in general agreed that it is more of a tribological phenomenon. So again, the bearing clearance or the third body particles play a significant role. Another study, again discussed earlier, if the fluid film lubrication breaks down for any reason, all those top points discussed earlier, that could potentially lead to squeaking. Well, if you look at the results, there are plenty of results available. The registry data is there, and this study from London, it showed, again, excellent results. And in this particular study, there was no squeaking, but however, some patients had clicking sensation. So there's no sound, but the patient could feel some. But still, the results were fantastic. So in my practice, when would I use ceramic on ceramic? Well, of course, I would definitely consider in young and active, but I'm very cautious in really overweight patients. If they're extremely active, I would be cautious about it as well. Or if they're extremely flexible, or if they expect extreme flexibility as a part of their daily life, whether it is anything to do with their physical activities, I would be very cautious. So my preference still in perhaps slightly majority of patients is a ceramic on poly, the modern poly, but ceramic on ceramic is considered in appropriate patients. This point about suboptimal cup position, so in certain anatomical acetabula, extreme anteversion or retroversion, is quite often you have to put the shell in that position if you can't put the shell in the correct angle you would like to put it in, because the ceramics don't come in lipped as lip liners. So in those situations, I personally prefer to use a poly with a lip liner. So with that conclusion, I would like to thank the organizers and the chairpersons here, and perhaps my colleague can follow me with his talk. Thank you.
Thank you, Dr. Kharkar. Thank you, Dr. Venu. I think because we have ample time left over, and one of the previous speakers again has missed a talk, so I think I invite Dr. Anand Arya to deliver his lecture on current concepts in elbow arthroplasty.
Good morning, Mr. Chairman and friends. It's a continuing of the talks from the King's College Hospital, London, but slightly different taste. You have had all about the hips throughout in the morning, so it's a completely different topic, and some of you may or may not be interested, but just out of interest, see what I have to say. King's College Hospital, Venu might have already mentioned, it's one of the oldest teaching hospitals in London. It's a level 1 trauma center, and it's one of the only 5 academic health science centers of the UK. And by the way, it's the biggest center for the liver transplant in the Europe. Now, for the total elbow replacement, like any other joint replacement, the main aim of doing this operation should be the relief of pain. But in the elbow, the 2 other indications which can be considered is the functional range of motion, because if the elbow is significantly stiff, it would make it difficult for the use the hand, and also if the elbow is quite unstable, then the arm would be basically useless. So along with the relief of pain, to gain the range of motion and to gain the stability also, the total elbow replacement can be done. The first 4 are the common indications for elbow replacement, certainly in UK. I'm not sure whether in India what the situation is, and these are the relatively rare indications for total elbow replacement. What I think is the most important quality of a surgeon is to know when not to operate. So you need to be careful that when you should not do this operation, and obviously the infection and the absence of functioning muscles or a non-compliant patient is certainly no. If you operate on a patient with a poor soft tissue cover or with a patient with unrealistic expectations, then you would definitely regret doing this operation. Obviously, patient need to know the limitations after total elbow replacement. It is advisable to not to lift more than 1 kilogram of weight in everyday activities, although up to 5 kilogram can be lifted in one-off events. Also, it is very unlikely that patient would ever get the full range of flexion and extension. So before you offer this operation to the patient, they need to be aware of it. I'm a conservative surgeon, and I believe that not only this operation, but for most of the operations, if the patient demands the operation, rather than you persuading the patient to have the operation, you are likely to have better results. A little bit about the terminology. Previously, the different types of the elbow replacements used to be termed as the constrained, unconstrained, or semi-constrained, but these terminologies no longer used. And nowadays, the better terminology is linked or unlinked. Because even unlinked design can be quite constrained design, because constraints depend upon the shape and the design of the joint. It's not just a question of linking or unlinking. So the better terminology to use now is the linked or the unlinked elbow replacement. In the unlinked design, the load is shared between the prosthesis and the soft tissues. So it is very important that you need to have the intact soft tissues. That means the muscles, the ligaments, and the bone there. Then only the unlinked design can be done. And initially, they did not have a stem, but most of the unlinked designs, they do have stems now. The unlinked elbow replacements are quite unforgiving, and if you do them with the deficient soft tissues, it would fail. And similarly, the component positioning has to be perfect, and if the component positioning is not right, very soon the elbow replacement would fail. While in the linked design, all the linked designs, the ulnar and humeral components, they are joined with some sort of a pin mechanism. Initially, the first generation implants were quite rigid, but now most of them has some sort of angulatory and rotatory laxity, which is, you can call it a sloppy hinge design. And because of those laxity, the stresses which normally can be passed onto the bone implant interface are not passed there, and that's why they do their job there. The kinematic studies also have shown that the linked designs, the kinematics of them is almost equal to the kinematics of a normal elbow. Now, with the linked elbow replacements, the indications gets broadened dramatically, because they can be used in all kind of soft tissue defects, bony defects, ligament deficiencies, and they're equally effective for all those indications where unlinked design can be used. These are some of the popular unlinked designs, and nowadays the Suture and the Kudo, they are mainly used, the people who use the unlinked designs. These are some of the linked designs. The top three are almost non-existent now. The GSB is used a little bit, but Cunard Moray is probably the most popular linked elbow replacement used universally. Discovery is a relatively new implant system, which is based on the same principles. There's a new group of the implants. Two of examples are here, which can be used either as a linked or unlinked designs. So surgeons have a choice that on the table they can decide whether you wanted to use a linked or unlinked design. So it's sort of one size fits all concept works here. Just to complete the type of the implants, the hemiarthroplasty implants and the lateral resurfacing arthroplasty implants, they are relatively new inventions. There are some indications for them. The long-term results are really not very satisfactory, but in certain indications, they can be done. The choice of the implants normally should depend on the extent and etiology of disease process. But in reality, nowadays the implant design has improved so much that most of the surgeons stick to one type of the implant, and they use it in almost all indications. And because the linked implant can be used in all those situations where the unlinked implant is required, So most of the surgeons stick to one design of linked implant and use it in all situations. So your inventory is reduced and you have to master only one technique. And normally this is what the trend is right now. I did my elbow fellowship in the Mayo Clinic with Dr. Morey and at the Tulane, New Orleans with Dr. Buddy Savoy. So I follow mainly Dr. Morey's technique for the elbow replacement. The position can be either the lateral or supine. It doesn't matter which one you're comfortable with. I use the elbow replacement in a supine position. Again, the time doesn't permit me to describe the approach in detail, but one of the posterior approaches should be used. I use the Brian Morey approach, in which the whole of the triceps is erased from the olecranon, from the medial side to the lateral side, and then reattached over there. This technique is very well described. The preparations of the humeral side, again, like any other prosthesis, is done by using the jigs. And the only thing is just a small point to note. It is always useful to do a lateral view of the humerus before doing elbow replacement, because sometimes the humerus is slightly curved, and if that is the situation, it might be useful to have a plate benders on the set, because then the humeral component can be bent to match with the curvature of the humerus. So it's a small thing, but sometimes it can make your life much easy. The ulnar preparation, people may think that it is easier, but actually it is difficult than the humeral preparation. And because the ulna is a very hard bone, and reaming the ulna is really, really difficult. And it is not uncommon to perforate the ulna while doing this reaming. And in fact, this is one of my patients, and I didn't realize it till I got the post-operative check X-ray that I perforated the ulna, and I have to take this patient back for a revision surgery. This was the patient who came to me from a different hospital, and this patient had this implant for about 10 years without much problem. So it's not necessary that the ulnar perforation would be a disaster, but one has to be aware that it can happen, and that's why one needs to be careful about it. All the linked implants have some sort of pin which can be attached, which joins the two implants there. In the Coulthard-Morey, this is a pin within a pin mechanism, and which is easy to put in, and it can be reduced also, it can be taken out easy. They have recently brought out a new system, which I think they still haven't marketed anywhere else except US, and in which the linking mechanism is different. The closure again is done by a special technique which Dr. Morey devised, in which the reflected triceps insertion is sutured back by making some bone tunnels and putting sutures there. And the arm is normally splinted in extension only with wool and crepe, and he doesn't recommend any physiotherapy. Range of movement should be started as soon as patient is comfortable. There are quite a series is available of comparing different kind of elbow results. These 3 or 4 elbows, they have got a long-term result. The Coulthard-Morey has the most longest elbow follow-ups, and their follow-ups is quite similar to the survival of the hip and knees based on the Kaplan-Meier charts there. And there's one comparative study also from Andy Carr from Oxford, which also shows that the Coulthard-Morey's results are much superior to the other kind of the implants. Just going to some specific conditions. In the rheumatoid arthritis, which is the most common cause for a total elbow in UK, the relief of pain is the most important thing, and anything unlinked or linked device can be used. The results have improved with the better designs and techniques, but I must mention that actually the number of the cases we do for rheumatoid is going down for total elbow replacement, possibly because the medical treatment of rheumatoid have improved so much that I'm sure it must be happening in the hip and knee replacement also, that we're getting less number of rheumatoid patients for elbow replacement. The osteoarthritis is not a very common cause for elbow replacement. You can get it sometime, but again the patient has to be aware of the limitations after this operation. And there are very few reports in the literature about the TR and the osteoarthritis. It is again mainly done for the pain relief. The range of movement, you do not get a great range of movement. Probably functional range you would get it there. If you're doing a TAR for the osteoarthritis, again be aware that the bone can be very hard and difficult to cut, and HO is very common post-operatively. So these things the patient need to know. In the distal humeral fractures, which are unreconstructible, the acute total elbow replacement is becoming more popular. And obviously, sometimes when the bone is so osteoporotic and fracture is so bad that you can't reconstruct it, then the total elbow replacement should be done. There are quite a good studies available which shows that the result of the primary total elbow replacement in distal humeral fractures are much better as compared to the result of the secondary elbow replacement when you do it after first doing the ORIF. So basically, if you think that this distal humeral fracture is unreconstructable, there is no point in trying to reconstruct it, then failing, and then doing a total elbow replacement. The result would be much better if you go for a primary total elbow replacement. This is a very interesting group of patients in which the total elbow replacement is quite useful, that in the non-union and dysfunctional instability. And I'm sure that a lot of the people would see some sort of horrible cases there where elbow is completely deformed and it's very floppy and the arm is not very useful. And in those situations, the linked implant can be done. I mean, obviously you need to assess the patient first, but the linked implant, if done and done well, they can give the reasonably good functional result. The linked implant also can be done when the distal humerus is deficient, and in the Cunard-Moret, up to 4 centimeter of the deficient distal humerus can be taken care of with a long flange. In the TER and the fused elbow is a really difficult situation. I don't think I've done any, and because in our situation we hardly get any patient of fused elbow, so I do not have any experience of that, but I'm sure that people who have done it have found it really difficult to do. You might have to cut a lot of bone there. There's a high risk of complication, including heterotopic ossification. The elbow replacement also has got its own share of complications. It is a complex joint, although it looks very simple. And like knee joint, it is very poorly covered by soft tissues, and it is traversed by the huge number of the important neurovascular structures. So one has to be very careful that you may get a lot of complications after this operation there. And some of these complications, infection, we all know is a disaster into the joint replacements. Intra-op fractures can happen. If you're doing a linked implant and these kind of fractures of the condyle happens, you don't need to worry about that. They would just heal, just ignore these fractures. And if the ulna is perforated and you know it intraoperatively, you need to revise it. Malpositioning of component is not really a problem in the linked implant, but unlinked implant, this can happen. Ectopic bone formation does happen, and sometimes you have to take the patient back to theater for secondary surgery. Postoperative stiffness, ulnar nerve damage, these are the avoidable, probably not postoperative stiffness, but ulnar nerve damage is an avoidable complications if you are careful. Loosening, like any other joint replacement, can happen. Instability, again, is not a problem into the linked implant. So, basically, just to conclude, I would say that now the elbow replacement, although it's a relatively new joint replacement as compared to other major joints, it is firmly established as the treatment of choice in older patients with osteoarthritis, post-traumatic conditions. Patients with the rheumatoid would definitely benefit by it. Previous surgery is normally associated with high rate of complication, and innovations and the reassessment continues. Challenges of technique are being recognized by designing more sophisticated instrumentation. Just like the Cunard-Moret has been redesigned now, the latitude elbow is also being, they're doing the design changes all the time. The more anatomical designs have also prompted the implantation of the humeral component as a hemi replacement, but again, the results still are not very satisfactory. And the ability to convert an unlinked to a linked articulation during surgery is also now available, which I think is very helpful. Thank you very much.
Now with this, the session comes to an end and the house is open for discussion. Any questions for any of the speakers for this session?
May I ask a question about the total elbow replacement in a special group of patients? I have one patient with a Charcot elbow. Okay, he has an unstable elbow, asking for something to do. What is your advice in this kind of patient?
I mean, taking the other situation, suppose the overlying skin is okay, and patient's distal function of the hand is okay. There's no neurovascular problems, no soft tissue problems, and the main problem is the ligamentous and the bony instability. And if the patient, what age the patient is of?
70.
70. So I think probably in 70 patient it would be quite reasonable to offer the total elbow replacement, but obviously one has to be aware of the high risk of complications. But I'm sure the instability problem can be taken care of by doing a total elbow replacement in that kind of situation.
Yeah. It's because if we borrow the experience from total knee, total hip, this is a contraindication. But upper limb surgery, I think, is totally different.
Upper limb surgery is slightly different than the lower limb surgery.
I agree.
So I think, patient is not going to lose anything, if it's such an unstable elbow.
I agree very much that we need to have a very realistic expectation with the patient.
Yeah.
That's why that patient is still under my care, repeat the consultation to see one day he really agree for the surgery.
Yeah.
But he asked for surgery, but not me. Yeah, I agree.
I can come and operate there,
Well, I have a question for the speakers for hip arthroplasty, Dr. Venu, Dr. Yadav, and Dr. Charlie. Just for my interest and the interest of the audience, if you have to choose a bearing surface for a 40 years old male, active, young active, and he is fit and can afford any type of bearing surface, in order of priority 1, 2, and 3, and head size, what would you choose?
My preference in a normally active person, not very excessively active person, would be ceramic on ceramic. But if I'm concerned about real extreme activity, I prefer to go for ceramic on poly. The results, if you look at the results, in most studies, ceramic and poly have got really good results as well.
Right,
So
but your first this thing will be a ceramic.
Yeah, I think the activity level is important for me, because I'm still
averagely active, assuming
average activity. I'm happy with ceramic and ceramic.
Right. And Dr. Yadav, what is your take on this?
Basically, I use cross-link poly and ceramic in majority of the cases, and the activity level in our country, in our patient, that is for the daily use. They do not go for the hockey play, athletic activity.
Is it metal on poly, or you're talking about ceramic on poly?
Ceramic head and cross-link poly. That is my choice.
So
Always use that.
Why would you not do a ceramic on ceramic?
Because of a lot of controversy surround the ceramic on ceramic, and it doesn't offer anything extra.
What is
Cross-link poly, if you literature, wear is very less in comparison to conventional polys. They are quite strong, versatile.
One question I would again like to ask, if you are talking about the head size, it always adds to the stability. But in our Indian conditions, the size of the cup is smaller. And if you are using a larger head size, the poly thickness decreases. What is your comment on this?
So then definitely in such cases, we have to use a smaller head, like 32, 28 as well.
And I believe that 32 heads and 30.
Then in every situation, you cannot go for 36. If cup size is around 48, 50, then you have to go for 32.
Any practical tips on implanting a ceramic head, since you have done a lot of ceramic on ceramics, Dr. Venu? Because you always fear once you are putting a ceramic cup, you fear regarding the inclination, the version, and once you are implanting it inside, you have to be slightly gentle with it. So any practical tips on that? And then the second question is, you said young and active on one side for the ceramic. That's you would like to do in a ceramic on ceramic in a young and active person. While on the other hand, you said you are not extreme. So what is the difference between young and active and extremely?
Right. Now, until recently, until probably about 3 years ago, ceramic and ceramic was my implant bearing choice for that group of patients. And activity levels are different between population we have in here and some of the patients we have in England and Europe in some areas. And sometimes you get postcards from the patients showing really dangerous, mountaineering with leg very high, and they, marathon and those kind of things. I'm really, really worried about these patients. Whenever I see these postcards, my heart sinks. What is going to happen to this ceramic? Will I get this patient back sometime with whatever major problem? So, having seen good results with ceramic and poly, with medium-term results. So now I have shifted to this group of patients to ceramic and poly, but I still do ceramic and ceramic if I'm not too concerned about it. But the only advantage with ceramic and ceramic, theoretical advantage, is this third body wear. If you have ceramic and poly, if there is any theoretical third body wear, then poly will wear out. But having said that, if in practice, we don't see that. In terms of the tips, nothing, there's no major scientific evidence, but I think it's kind of habit we develop. Now, since ceramics were introduced, they changed the surface of trunnion. Before ceramic was introduced, the ridge of the trunnion was very smooth. And because the contact point of ceramic head to trunnion was slightly unpredictable, they introduced slight ridges. And that's the main reason why we're concerned about banging the ceramic head. So before putting the ceramic head completely dry, because the trunnion, the property of trunnion is if there's any fluid trapped in trunnion, it doesn't work that well. So you need to make it completely dry and put the ceramic head. Before tapping it, I twist gently. I don't. If I try to twist, if it doesn't move, then I got conical trunnion and exactly conical shape of the inner surface of the ceramic that perfectly matches. It toggles, twists, and then if I'm happy, bang it. And in fact, again, the same thing with liner. Liner, I spent quite a bit of time making sure that, because I had that X-ray I showed was my fault. So I had a couple of cases of such experience. I take plenty of time. If you look at the shape of ceramic liners of different companies, the Dupuis ones, Pinnacle has more parallel cone, whereas other companies have more angled cone. In other companies, you can just simply slip the ceramic, it usually falls in, or you might need slight adjustment. But with Dupuis ones, because the cone is very parallel, you have to be very precise and take time, make sure that it is perfectly seating, and you can bang. I bang it hard. Ceramic liner, no problem. If it sits in properly, I bang it. So that's the kind of technique I use.
A little comment about the ceramic and ceramics. I think it has earned its disrepute from the very early years it was used. Nowadays we have very safe ceramics, and the reason why I would prefer ceramic and ceramics is because its particles, the wear particles, they are not bioreactive. The polyparticles are bioreactive, so the body reacts to it and creates an aseptic loosening in the longer term. It's kind of a slow poisoning, I would say. But ceramic on ceramics, the particles are not bioreactive, so although we all know that ceramic on ceramic bearings wear the least in all the bearings available, and they not being bioreactive helps a lot. And I would say, go to the extent to say that if the fixity is good, if the alignment is good, this will give you a hip for life.
Yeah. That's Kamaldeep from Glasgow.
May I ask the expert panelists if the ceramic insert is improperly sit, how can I take it out and reinsert? Because this is the most difficult part. I never encounter one, but I think sooner or later I will encounter. So I need your expert advice.
Do you have any comments? Shall I?
do not use ceramic.
All right, good for you.
I'm not
No, in fact, I have, that we call this as registrar syndrome. Probably Kamal knows about it. This is called registrar syndrome. Whenever we let registrar do, first case always happens to be that this gets stuck. First case always. Now, when that happens, you need to tap the liner gently without making sure that it doesn't actually impact on the ceramic. When you just gently tap, it bounces and quite often goes back into correct position, or it bounces and you catch. There are actually dedicated instruments for that. Dupuis certainly has a peripheral rim impactor. It goes around the cup and you bang it in. I always use the suction, this suction thing. So I hold the, hold the liner with the suction, Go in, feel the rim of the cup, make sure that it is parallel all around. But to take it out, you just simply tap.
But probably you have to be extremely cautious.
Because that's a rim impactor. It's not always
Correct.
available.
Yeah.
Unless you are preparing to something wrong.
So you want which instrument? In Corel set, there is an impactor, very thin impactor. It is in the set.
The impactor for the femoral side.
For the femoral side,
That's the
Corel
femoral
set,
side with the ones you have to impact the
because that
bones.
thickness is just enough for the shell. So you have to make sure that it doesn't actually touch the liner, because if you impact on the liner, it will break.
But probably before impacting the liner, you have to be extremely cautious, just doubly check it. You don't land up in this type of problem.
It's because in Hong Kong, we have one what we call Saturday clinical conference meeting. Another hospital presents one case, and that surgeon forcefully impact the ceramic insert, and then finally still do not sit properly, and then let go, and then around few weeks later, ceramic fracture. Okay. So we discussed how we can remove the ceramic insert properly. In fact, there's no good answer. I think if we have the good instrument, then this is excellent, but it's not always available. We think about using the bone punch, okay, to tap the shell, the periphery repeatedly. One surgeon commented that he has tried before, tap it 200 times. Still the ceramic insert is still there. So how can we do? Then is that take the whole shell out.
You feel it's an unanswered, but it's not a solved problem. It still remains unsolved. But probably the experience with the registrars, that's probably. Yes, Dr. Charlie, you would like to add something?
About putting the ceramic liner into the shell. If the shell is very thin from some company, when you putting the shell in, you use the rim, you rim less than the cup size, you may cause the shell to deform. So sometimes when you want to use the ceramic liner, it is advisable to rim it line to line with supplemental fixation if you are not sure, because when the shell is thin and you under rim it, you may cause the shell to deform. And when the shell deforms, you put the liner in, the liner may be eccentric easily. So if you limbing the shell line, limbing line to line with screw fixation or something, you can put in the ceramic liner easily. And it is when to take the ceramic liner out, tapping around is the only solution to take it out, because anything else you cannot do anything. But you have to be very patient, and you have to know where to put. Sometimes you tap in one side, it will not going out. You start to tap in all around. I think it is the only method to taking the ceramic liner out.
As long as you haven't impacted in that really wrong position, with one tap or occasional two taps, it comes out. And that is, the registrars, they get so excited when they see you tap it, it comes out, or something it sits back in. And the point you told, Charlie, is very important. We miss that point. So the cups always deform anteroposteriorly, because the cup wedges between anterior and posterior cortical wall, and it deforms slightly. And the reaming technique is also important.
Right. Okay, one more question from this. So you're a cemented man. Thank you, Dr. Yadav. And I I think if there are no more questions, I thank all the speakers that delivered excellent lectures, and I also thank the audience. Thank you very much. I think.
Sir, reduction of an intertrochanteric fracture is normally the close reduction is obtained in 95% of the people by traction and internal rotation. I am not talking about this 95%. I am only talking about only those 5% where the open reduction is needed and the closed reduction is not successful. So I am taking out those 95%, so do not confuse the issue. Those where you get reduction, there is no issue at all. Normally, we do this approach for the DHS. What we do, we go behind the vastus lateralis is taken out, and we go to the bone. This is the way in which normal DHS we do it. But when you are planning an open reduction, so when at the closed reduction, traction, internal rotation, joystick, everything has not given you the reduction, now you will have to plan an open reduction. So if you plan an open reduction, your incision has to be modified a little. Because when I plan an open reduction, I do not take this approach, I take a mid-vasti approach. So you take a mid-vasti approach and you take the vastus anteriorly and posteriorly, and that is the one which makes the life far more comfortable. Because when you take this anteriorly and posteriorly, the fracture is just there visible. If you take behind the vasti, then the big vasta is there. It's very difficult to take the whole vasta anteriorly in order to see the fracture surface. And that is the reason why if the full vasta had to be retracted, it's a big bulk comes in the way of visualization, and that's the reason open reduction becomes difficult. When we go through the vasti, it is a little bloody approach. You will have to really look after the few bleeders which are there when you go through the vasti. But once you have done that, and you need to have a retraction, which is going to be, ordinary spike will not work because the spike will come in the way. You take a retraction, a beavers, and you take out the beavers so that the muscle is away, and you will be able to go right into the anterior part, and you can get visualize the whole reduction very well. Once you are there in the fracture, you don't have to find out about the mechanics, because you see two fracture surfaces, internally rotate, externally rotate, abduct, you will be able to do it visually, whatever you are there. When you're doing it blind, it is all blind procedures. But when you do it open, it is there which gives you hold the two ends and you will be able to do it. This is the typical fracture. This is the typical fracture where the surgeon tried to reduce, he couldn't reduce, and that's the reason why he ultimately fixed up in this position. Any idea how would you have reduced this fracture properly? Anybody? Amit? Keep this picture in mind. It is only a two-part fracture. Iliopsoas is pulling. This fragment is in external rotation and flexion. So you have to put the distal fragment into the external rotation, then only the two bones will come together. If you put an external rotation, it's very difficult to really fix it up. And that's the reason why this is the issue which you will be able to do it. This is the one which I went ahead and I fixed it up, and it was completely held up. But that is the one which later on. This is the typical thing which you will see. This is just remember this picture, this is a typical deformity of a fragment is in external rotation and abduction. Normal internal rotation of the distal fragment will not reduce this fracture. And then you can reduce it with the external rotation. This is another one. In a lateral view, it is up and down. You can see there is no way with joysticks or anything you can really reduce this fragment. So the way to go about is, if you externally rotate, it is not very easy to pass the guide wire. And hence, proximal fragment, you put a Steinman pin, which is not going to come into your direction of the DHS screw which you are going to put. Put the Steinman pin, internally rotate and adduct, and then you will be able to get two surfaces together and then you will be able to pass. As you can see, you can get two surfaces together and pass a fixation. So this Steinman pin is the most important thing, and that's the reason why, unless it is open reduction, you will not get end-to-end position. The fracture implant is a very secondary situation. The main situation is a reduction. Reduction, unless you get, you will never be able to get this fracture unite. Once you get this perfect reduction, you have a very good fixation there, and this fracture is going to heal up very well. The upper fragment is externally rotated, as you can see here. You put in a Steinman pin, externally rotate, adduct, and this fragment is ultimately put together, and these two fragments will come together. They will now you will see the good shape of the head, otherwise you will not see the good shape of an head. This is the way in which you can do the open reduction of a fracture, which is like this. This is the typical again position which you can see. Now, since it has been there, we have been doing it, no exaggeration. My theater nurse tells me, sir, this is the one which you will have to do an open reduction. Because she has seen this quite a few occasions, and you will just do the external rotation and the fracture comes there. And you will be able to fix it up. If you can't reduce it, this is the one the surgeon tried hard to reduce it, couldn't reduce it because he did not know that you can do an open reduction in an intertrochanteric fracture. That's the reason he abandoned, and it ends up into a non-union. Keep these images in your mental eye, where external rotation of the distal fragment only will reduce and not internal rotation, which is normal. These are the typical pictures. Once you see, you know very well that this is the one which will need that external rotation, and hence that's the one which will need the sand spin into the proximal fragment, and with that you can really reduce the fragment. And these are the pictures which you keep it in mind. Almost all the time it is two-part fracture, which is the one which is really displaced like this. This is another type of a fracture which is displaced, and when we did the reduction under a lateral view, it is not reduced. This is the CT which was done for some other reasons, and you can see this fragment is locked into each other. And that's the reason you go down. I put in a mixture, and once you put the mixture and rotate it, the fragment rotates, and you can get the perfect anatomical reduction which is established. Once you establish the anatomical reduction, then only you must fix up the fracture. So intertrochanteric fractures like this, where the reduction is not possible, everything has to be first done is the open reduction. And that open reduction, you don't need to really learn how to do it. It is automatically you will be able to get it. Now here is the fracture. On the traction table, you can see this piece is wedged into the trochanter, and this is out. This is on the traction table. You have to go down, hook it out, disengage this upper fragment there from the trochanter there, and once you have done that, take another hook, push it down, and you will be able to fix it up in an anatomical position, and this becomes all right. Same thing can be done for a PFN when you are doing. Here is the one fracture which I was doing a PFN. Here was the reduction X-ray. You can see still there is a small opening there which is otherwise maybe acceptable. Here it is the one, you can see it is in varus. I passed the nail. It was in varus. So again you take the hook, give a distraction, and ultimately go ahead and do a PFN. PFN also you can do an open reduction, and you can do a PFN. There is a myth that if you do a PFN you can't do an open reduction. That is not true. Reduction and into the cancellous bone like intertrochanteric fracture, opening up the fracture site does not harm the healing process. You will get exactly the same healing process. So don't confuse the metaphyseal fracture with the diaphyseal fracture. Diaphyseal fracture where the healing can be delayed if in case the whole hematoma is disturbed. Here is the fracture. No way, traction, nothing happens, as you can see very well. You go down the way I mentioned about, put in the leg screws, get the fracture, and you will be able to get the fracture very well. Now this is the way in which you can go ahead. Here was the fracture. The surgeon did the operation of PFN. In AP view everything looks very good. 3 years, pain, pain, pain. You can see in the lateral view, these two fragments are not together. As soon as I removed the PFN, these fragments were mobile. So there is no way you can treat this fracture just like that by bone grafting alone. You do, it's not going to work it out. So went down, did the 95 degree without the fracture table, and these two fragments, did the leg screw, perfectly fixed it up, and then for whatever the peace of mind I put in the bone graft and neutralized with 95 degree. Here are the leg screws which you can see, and this gives you the best possible chance. In conclusion, reduction is the important thing. DHS or PFN is not more important than a reduction. At open reduction, once you see the fragments, reduction maneuvers will be dictated in each fracture by seeing it. Prior knowledge of whether to do internal rotation or external rotation of the proximal fragment is also redundant. So don't get into that confused. You can see very well, you will know how to reduce the fractures. In those 5% where you do not get reduction, must do an open reduction. Reduction maneuvers is different in different fractures. Analyze it, reduce it, and then only fix it. Thank you.
Questions? You can ask question from Dr. Tanna. Anybody?
Sir, my question. In a situation when the proximal fragment is externally rotated, and one of the technique is to externally rotate the distal limb, distal fragment, then it is very difficult to pass the guide wire and
that is what I said, and that is the reason I said that it is, even if you get a reduction, you can't really pass the guide wire like that.
Yeah.
And so, send screws in the proximal fragment internally rotate, so the distal fragment will remain in the position in which you can pass.
Sir, in subtrochanteric extension of the fractures, like you shown in some slide that PFN failed to reduce the almost vertically split fracture, how do you put lag screws? How you expose the fracture and?
Open it up. You open it up. This fracture I would open up even in a revision, I opened up without the traction table. So once you don't put the traction table, you will be able to see the fracture surfaces very well. Once you see the fracture surface, clean it out, completely clean it out with the fibrous tissue which is attached, put the clamps and two lovely leg screws, you will go and you will realize that it has given you a perfect reduction and a good stability which is achieved. Even that situation, I would have gone on day one, open reduction and done the leg screw there.
Sir, if
I do not feel, I will do the nailing. If it does not heal, then I'll do the grafting. If it does not heal, then I'll go ahead. I think the attitude has come mainly because I treat almost 100% of the patients are private, well-paying patients. On day one, they are willing to undergo anything.
Yes.
But afterwards you say, then it is too much of a hassle because you know this patient 3 months, 4 months, not united, again graft, not united. That's not acceptable. Day one, do everything, whatever you need to do.
Sir, supposing first suppose that we will be able to achieve the close reduction, and if it fails, should we convert the patient, should be transferred from fracture table to the normal table?
No. In this subtrochanteric extension, probably it would have been easier to do without the traction table. But intertrochanteric fractures, I do it only on the traction table. So you go ahead, as I mentioned to you, opening up the vasti, go anteriorly and you will be able to reduce. This was a little extension in the lower down, and since I was doing a revision of that, of a non-union, that's the reason I said I don't need the fracture table there.
Thank you.
Because now I was not relying on the fracture table for the union or for the reduction. Yes, Doc, come to the mic.
Sir, is there any role of trochanteric clamps recently introduced?
Trochanteric
Instead
clamp?
of shank pins to get the reduction, trochanteric clamps are newly introduced.
Yeah, if you can use a trochanteric clamp, there is no harm in that. Because one person will have to hold the trochanteric clamp,
yes,
hold it and then rotate it till the time you get a reduction and put it. Anyway, you need a control on the proximal fragment. How you get it is your lookout. towel clip, if you can put it, still you will be able to get the control of the proximal fragment.
Sir, in subtrochanteric fracture which you shown, so it is very difficult, sir. I tried 2 cases, but it is very difficult to do on fracture table.
That's the reason I said I would do it on an ordinary table.
Yes, sir.
That's exactly the reason I said fracture table, the fracture is behind and you really can't see it. On an ordinary table you can rotate the leg, see the fracture, now you know where you are and you can really do it. As a matter of fact, so many people do a DHS on an ordinary table, PFN on an ordinary table. Occasionally I also do it because I don't think it is that difficult. We have a hesitation only because we think we will not be able to get a lateral view. But the lateral view, if you have to take, you really externally rotate the limb and do it, you will be able to get a perfect lateral view, and there is no issue at all about it.
The PFN you were talking about, one PFN you have done, you showed one case that after putting the nail you have tried to put the bone hooks.
Bone hook?
Bone hooks or reduce that gap.
No, I think because, you know, if you can analyze that PFN, fracture is medial to the nail and it is medial to that fragment. So you put in first a PFN, the nail, now you want to reduce. The PFN, the maneuver is you put the nail, give a traction, give a rotation, get the perfect reduction there of the intertroch. It is what I do it. First I go ahead and put in a nail because it wasn't possible to reduce it by closed methods that before I start the PFN. Otherwise I attempted it. Yeah. I attempted it, and that's the reason I said, and I opened it up also. I opened it up like the same way as it is. It was opened up anteriorly. I saw the beak, and I realized it is the whole fracture is medial to the nail segment. So I put in the nail, then reduced it, and then fixed it up. Okay. But otherwise, as very rightly Goel said, first reduce it. Now in this situation, once it was not possible, I had to do the open reduction, hold it there, and then put in a PFN, which I felt was not really required because the fracture is medial to the nail. Govind, anything? Yes? True lateral. Jara, can you use the
true
mic?
Lateral view of the neck of the femur at 40 degrees.
If you want to take a true lateral view of the neck of the femur, it is said that if you keep this tube and this at 40-degree angle, then you get a true
frog leg position without the table you are talking.
Yes.
Yeah.
So it is not parallel.
No, it's not parallel. It is like whenever you do the proximal humerus, you do it like this and you will get a lateral view.
Any other question? If no, thanks, sir.
Thank you.
The next topic is by Dr. Amit Ajgaonkar from Mumbai, and he will be talking on management of terrible trade of elbow.
It's not purely management, but terrible triad, no matter how many times we study it, we remember it, but we tend to forget the basic pathoanatomy. We all should first know the basic, that's the most important thing in a terrible triad, what it is. Generally, we have an impression that it is a dislocation, it has a coronoid and a radial head. But we need to know the stabilizers of the elbow. Anteriorly, we have the coronoid. This is the anterior, we have the coronoid, the most important stabilizer, the brachialis muscle and the anterior aspect of the capsule. This is very important. Now medially if you go, you have the medial collateral ligament, the coronoid process again, and to some extent the medial epicondyle. Lateral, the other most important thing is the radial head, the capitellum to some extent, and the lateral collateral ligament complex. That's very important. And posteriorly you get the olecranon, the triceps, and the posterior aspect of the capsule. Generally the mechanism is fall on an outstretched hand, extension. Now this extension could give rise to valgus or varus, which is not very common. Generally it is valgus. Axial load, valgus and supination. The ultimate result, end result is a the most important ligament is the lateral ulnar collateral ligament, and it consists of various others also. The medial collateral ligament, again it has a posterior bundle, the transverse bundle, but again over here the most important is the medial collateral ligament or the medial ulnar collateral ligament. The proximal ulna has got these very important attachments. This is the attachment of the anterior capsule, this is the brachialis muscle, and this is the sublime tubercle. Sublime tubercle has got the attachment of the anterior bundle of the medial collateral ligament, and this has to be always kept in mind throughout this lecture, because coronoid, if the sublime tubercle or the medial aspect of the coronoid is involved, then you have to go down and fix it, otherwise your medial collateral is out. It will give instability. Medial muscular anatomy, you always have to remain below the flexor pronator group of muscles. Always below the flexor pronator group of muscles whenever you approach the elbow from medial side, because your most important structures are above. Laterally, you have to remain below the extensor origin. And for all diagrammatic purposes, I'll show you how it happens. This is a dislocation. Coronoid takes away with it an avulsed segment of the anterior capsule. Coronoid gets fractured and the capitulum hits on the radial head gets fractured. Here, this is valgus, medial collateral ligament, trochlea, it hits on the coronoid splits away, the capitulum hits on the radial head gets fractured, and the last to fail is the medial collateral ligament. This is the medial collateral ligament which fails last in posterolateral or valgus instability. That's the most important thing in terrible triad. Now the lateral collateral ligament fails the last in posteromedial or varus instability, varus stress. Varus stress, varus, and the coronoid gets fractured because the trochlea hits on the coronoid, it gets fractured, it goes away, and the last to fail is the lateral collateral ligament. In any varus stress, the radial head does not get fractured. It is the coronoid and the lateral collateral ligament. The numerous patterns are of terrible triad: posterior dislocation with a radial head, the typical terrible triad, that's the dislocation, radial head and coronoid, and the last and the most severe thing is transolecranon fracture dislocations, wherein the split is transolecranon, you have an anterior and a posterior splits. Here I already told you that you have to remain below this group of muscles whenever you are approaching. You have the Kaplan's approach which goes between the common extensors, but whenever you go between the common extensors, it's a very taut structure. You will find very tightness and inability to retract. So avoid going between the common extensors. The best approach is this, the Cocker's, which uses the interval between the extensor carpi ulnaris and the anconeus, and easily you can reflect it and go down and see your the lateral side of the elbow. This is the exposure, and for all these posterolateral instability, that is valgus instability, valgus type of injuries, the coronoid, only the anterior chip or a small anterior part is fractured, and this small part or tip part of the coronoid can be sutured. And while putting these sutures, you can put these sutures from the lateral side after seeing the radial head, but these sutures may not engage this small fragment. If they are not engaging the small fragment very well, you can go down and you can pass your sutures through the anterior capsule. Don't worry about that small fracture, but pass your sutures through the anterior capsule, you got your anterior stabilizers intact. And this is the way you do it with suturing, or you may just put 2 screws. Putting 2 screws from anterior to posterior is a difficult task, because to approach the anterior side from the lateral aspect is very difficult. If you want at all to put screws or plates, you have to go down medially. Before fixing or reconstructing the radial head from the lateral side, you have to just peep into the radial head. And do not fix the radial head first. Go down, see you might not see the olecranon, but you will see this coronoid. And this coronoid is seen, and reduce it, pass sutures through the anterior capsule and do a proper suturing of the the coronoid, and then approach your radial head. Now radial head, where you have to put your plate. If you want to plate it, how? The plating is done using the safe zone. Now what is the safe zone? It is the anterolateral 1/3, this anterolateral 1/3 of the radial head, which does not have the articular margin. It does not articulate with the sigmoid notch of the proximal ulna. So this can be approached only in the mid-prone position. You have to keep it in the mid-prone position. Do not supinate, do not pronate. In the mid-prone position, you can apply a plate laterally. Here is a case wherein we have done this plating. Again, the way the plating is done, this particular thing, if you apply a straight plate on the radial head laterally, this is going to happen. The radial head will overstuff your sigmoid notch. If it is overstuffing the sigmoid notch, then you will have ultimately reduction in your supination and pronation, or to some extent pain. The radial head is typically this shaped, and you have to anatomically contour your radial plate. Definitely we do not have any anatomically contoured radial plate, but go down, use the mini fragment set, and you can contour it. You may put 2 screws into the head and 2 screws into the shaft. You may lose your center screws, but you get a good reduction of that radial head fragment. If replacement, you have to decide how to do it. Close inspection of the capitulum is very important. Your replaced radial head should match the capitulum, and it should not overstuff the sigmoid notch. Again, the overstuffing will cause problems with pain, restriction of movements, and so on. Ulnohumeral joint has to be seen after putting your radial head replacement, and that has to be uniform. Otherwise,